Good evening, everyone. Yashoda Group of Hospitals welcomes you all for the academic activity of this week. And this week we'll be discussing about the academic research activity, research work in emergency medicine. And in this, first and foremost, I would like to discuss about the basic thing that has to be accomplished before starting any research activity. That is the formation of the research protocol. The research protocol is just like forming a formulation of a game plan before any sports activity. A successful formulation of a game plan would result in a successful result of in any game. In the same way, formulation of a research protocol would lead to successful completion of a research activity. So now let us see what are the steps in the formulation of a research protocol and what are the things that that are the components of research protocol. Next slide. Okay, as we see, the outline of a research protocol consists of various steps, which starts with the title, and there are different steps starting from the introduction to the what are the objectives, what are we looking for, how are we planning to go ahead, what is the methodology, and what are the expected outcomes, ethical considerations, duration, and last but not least, the budgetary estimate. Among these, the first thing is the deciding the topic. We have to choose what is the topic that interests us, what is the topic that drives us to make a good research activity. So deciding the title is the one of the most important step, and we can make use of various things in order to decide the topic. Like we can make use of various search engines, especially the PubMed search engine, and check for what are the recent activities, what are the recent research activities happening in the field. After that, we need to go ahead with the introduction and deciding what is the background and rationale for doing this study. First of all, concisely introduce the topic area. What is the relevance of doing research in this particular topic? Brief about the previous research studies that have already happened, whether it is by others or the researcher himself. And then here we need to answer certain questions. What are the untouched areas? What are the unanswered questions in this topic? And discuss the points that need further clarity. Also, we need to cover the unexplored areas. What are the gaps in research? Where should we fill these spaces? And then decide what are the areas that need more research. Then comes the rationale. Why should we actually do research in this particular topic? Why is the need for this current study, and how does it add to the existing knowledge and the practices? How does it change the guidelines? That is the thing we have to keep in mind when we go ahead with the research activity. Coming to the objectives, the primary objective should be very crisp whenever we do it. It should be explained in a single sentence or two. And whereas the rest of all the objectives are secondary, and they help us to tell us how we achieve our overall objective or the primary objective, and how does this answer our research question, or how does it prove or disprove our hypothesis. Once a clarity is brought about the introduction, what the topic is, the introduction, background and rationale, and what are the objectives, and how to reach the primary objective, then we need to decide what the methodology is. How are we going ahead in the research activity? The research design consists of deciding whether the study which we have chosen is a prospective study. That is, the subjects are followed during a timeline and then the data is captured. Or is it a retrospective study where there is a existing data and then we study it retrograde? Are we doing it in the form of a clinical interpretation, or are we going to reaching to the community level, or are we doing any laboratory based trials where various lab investigations are done and the data is interpreted, or is there any intervention involved? And research design also should give a clarity whether we are collecting the data at a particular point of time, that is a cross-sectional study. Is it involving specific groups or any particular cohort of a population or the population in general? Then we have to decide whether it is a randomized control trial or a trial where subjects and normal individuals, that is the controls are used, that is the case control study. Then we have to decide about the sampling methods that we have to use for this study. The sample size can be calculated by by the procedure of computing it. And we have to decide who or what are going to be our subjects. The study location has to be clarified, whether we are doing it at what location we are doing it, the country, state, the city, village, and are we doing it in a setting of a which setting, whether it is a hospital setting or a non-hospital setting. Then comes the research tools. What are the tools we have? The various tools for the collection of the data, whether they are quantitative methods or qualitative methods, or a combination of both the methods. Then comes the clinical interpretation, whether any anthropometric measures or a combination of both are done. The data collection procedure is very important in the outcome of research activity. This mentions the data collection mentions the process that is involved in the collection of the data, and gives a clarity about who collects the data and how are they expected to do the data collection in a methodical way, so that we get a good quality data. For this, we need to have a mechanism of a regular checks so that the good quality data is captured. Once the data is entered, it has to be analyzed appropriately using statistical procedures. And the researcher should have a basic thing in the mind. They should know what is the thing that is expected from my study or the research, and how the results of my study is going to help to fill the existing gaps in the research, existing research or the policies or the practices. Every study or every research activity must have ethical clearance before it is done, and we should specify the institute or the university from where whose institutional review board or ethics committee is approached, and they have given the clearance. And all these studies, and particularly this clearance is very much needed whenever there are interventions or invasive methods that are involved in the study. Consent should always be taken in a written and informed form. And in case of children, the consent from parents is mandatory. The researcher should have a good idea about the duration and the time frame. In what time I'm going to complete my research? What are the steps that have to be done in order to complete the research activity on time? There should be a time frame, and each and every and the data collection and each and every step has to be followed in a methodical way, so that the research activity is done within a particular duration. Coming to the references and bibliography, they have to be arranged alphabetically, and also the references should be presented numerically. Last but not the least, the budgetary estimate. This provides estimates under specific heads in Indian rupees for each year of the project and for the complete duration of the study. With this brief introduction, I would like to give some tips regarding the research activities. Take enough time, decide about a good idea which excites you, which encourages you to do the research activity. Start by writing a summary. Start by writing a summary of the proposed project. Demonstrate and update knowledge of the field. What are the gaps in the knowledge? How to fill these gaps? How to go ahead with the research activity? And then present the aims and objectives clearly and concisely, especially the primary objective and the secondary objectives that make the research activity clear and on time. Always use a simple and clear language and state the obvious. Usage of appropriate charts and graphs helps us to interpret the data in a very effective way. Anticipate the questions that may arise, and know the limitations of the study. Always take the help of a colleague or an expert to review before you finalize the study. These are the tips I would like to give. With this brief introduction about research work in emergency medicine, I would like to give it over to Dr. Fani, who will discuss about research activity that has happened in our department. Over to Dr. Fani.
Thank you, sir. It was a very good brief introduction about what we are doing today. So I would like to carry out from here on. That is, we have done research work on optic nerve sheath diameter. So, and this was taken as a thesis topic for one of our residents also. So I first I would like to just say what is the optic nerve sheath and optic nerve sheath diameter. See, actually, the optic nerve which is there, it is a misnomer. Most people, they think that it is a part of the peripheral nerve system, but it is not. It is a part of the CNS. As during the developmental stages, it arises from the diencephalon. Okay, so it is a part of the CNS and not the PNS. And the optic nerve, as you can see in the image, surrounded by some bridging vessels, the arachnoid dura and the pia matters, and also the central retinal vein and the central retinal artery. And the meningeal layers surrounding the optic nerve are in a continuum with the three meningeal layers of the brain. So it's like it becomes a very important part. And even in traumatic and non-traumatic patients, this optic nerve sheath diameter can be, it can raise. So and it can indicate that there is a raise in the ICP also, that is the intracranial pressure. So coming to the next slide. Next slide, as I said, the optic nerve is covered by the dura, pia, and the arachnoid spaces, and also the blood vessels there. And the thing is, around the optic nerve there is CSF. Okay, so it percolates around. CSF percolates around this, and this increases the pressure, and this increases the ICP, and in turn it raises the ONSD. That is, optic nerve sheath diameter will be increased. So that is why we have to know what are the causes of optic nerve sheath diameter increase. See, there are several causes which are traumatic and non-traumatic. So non-traumatic, there are intracranial vessels, cerebral edema, increased CSF volume, and increased blood volume. SOLs like neoplasm, abscess, and hematoma. Cerebral edema conditions where cerebral edema can occur are encephalitis, meningitis, hypoxic injury, and also hepatic encephalopathy and stroke. CSF increase can be seen in conditions like hydrocephalus and choroid plexus papilloma, and increased blood volume is seen in CVD, that is cerebral venous thrombosis and spontaneous IC bleeds. So these are some non-traumatic etiologies, and we have conducted this study on non-traumatic patients only. So if you see the review of literatures, that is, if you see the recent articles which are published. So this is an article which was conducted by Nirvin et al. It was conducted in 2011, and it was conducted in patients of post-pubertal females. 99 post-pubertal females were taken, and they were compared to 35 normal females. And in them, the intracranial raise in the intracranial pressure was studied, and it was studied using a sonographic examination, that is the USG, and it was found that the cutoff value indicating raised ICP was around 6.05 mm with an area under the curve of 0.8. And this study consisted of sensitivity of 73% and specificity of 91.4%. And this was another study which was conducted by Qamar et al., that is Qamar et al. And this study was conducted from 2013 to 2015. And it was divided into two groups, which were one group was with pathology on the CT brain, and group 2 was with a normal CT. And when compared with these two groups, this prospective study which was done, the ONSD values of group 1 were 5.4 plus or minus 1.1, and group 2 were for 4.1 plus or minus 0.5 mm respectively. So the cutoff value for determination of midline shift, so the cutoff value was 5.2 or 5.4. So this is another journal of neurological sciences. It was conducted by Pablo et al. And the cutoff value for detecting raised ICP was 6.3 mm with a sensitivity of 94.7%. And also after therapeutic lumbar puncture, 87% of the cases which were found to have raised ICP or there was a optic nerve sheath diameter increase. After the LP, there were 87% of the cases were seeing the value coming back to baseline actually. So this was done by Afshin Amini et al. And this was published in the American Journal of Emergency Medicine. And this study, it was compared with ONSD values with ICP measured by lumbar puncture in 50 non-traumatized patients. And the mean ONSD for patients with raised ICP and normal individuals were 6.6. So this yeah. So this is another study conducted by Joshua et al. This was a transocular ultrasound, which was used to measure the optic nerve sheath diameter to see whether there was an ICP raise or not in trauma patients. Rest all the studies were conducted in non-traumatic patients. This study was conducted in traumatic patients, and it was found that with raised ICP, requiring surgery, the ONSD was averagely measured as 0.62 centimeters, and normal pressures were ensured if the ONSD was less than 0.5. So there are other studies which were compared, and this is another study which was conducted by Mason et al. This was an ultrasound USG measured optic nerve sheath diameter to accurately measure the ICP for changes in the ICP, and it was found that in all patients ICP increased over about 20 mmHg during manipulation of the trachea, and once the tracheal manipulation was stopped, the ICP as well as the ONSD decreased and immediately came back to normal. So these were some of the popular studies which were conducted using ultrasound and measuring the optic nerve sheath diameter in patients with raised intracranial pressure. So by these studies, we can say that USG is a very useful and a very easily available tool in the emergency room or the emergency department, where we can see the optic nerve sheath diameter, the diameter of the optic nerve sheath, and tell that whether there is an increase in the ICP or not. Because generally, if we want to measure the ICP, we have to do invasive monitoring or we have to get a scan done, like a CT or an MRI. But in some patients, we cannot do the MRI or CT because of one thing is the cost constraints, one thing is the patient has to be shifted, one thing, the other thing is that the patient hemodynamical status. So if the hemodynamics are unstable, if the cost, if the patient is not affordable, we cannot tell whether there is an increase in the ICP or not. And for this, ultrasound is a very good tool. It can be done easily. It is very less time consuming, less cost, and the patient has we can just keep the patient in the emergency department and do the study, do the ultrasound to know whether there is an increase in the ICP or not. So I think this is a very good tool, and it should be done in every emergency department, whoever is practicing emergency medicine, and even for the emergency physicians and the residents also who are undergoing the training. I think it is a very useful tool. So based on these studies and all, there were various other studies which were conducted in the past. So if you see the cutoff values of the ONSD, they are ranging from 5.0 to 6.3. Almost every study has a value of 5.0, 5.9, 5.0, 5.2, 5.3 like this, and the highest being 6.3 with a sensitivity ranging between 70 to 100% almost. So I think ultrasound, again, when you compare different studies, ultrasound is a very useful tool, and it should be done in every emergency department. So now I would like to Qamar to take it over from here and tell regarding the other aspects of the study. Thank you.
Yes, Dr. Fani, absolutely, I agree with you. Ultrasonography is a very important and basic tool in the armamentarium of emergency physician, and it is very useful for assessing the raised intracranial pressure just on the bedside and immediately, which is very much reproducible immediately too. And especially it is very useful in cases of patients who are irritable and any patient who is unstable and we are not able to shift the patient to the radiology department for the scans. With this, I'd like to give over to Dr. Qamar to continue the discussion.
Thank you, sir. Am I audible, sir?
Yes, Qamar.
Yeah, I would like to start my presentation. Yeah, is the slide visible, sir? Hello.
Yes, it's good.
Yes.
Yeah, good evening, everybody. As Dr. Phanindra has explained about the various studies done on optic nerve sheath diameter, most of the studies are done in traumatic settings, like patients who come with traumatic brain injuries, or in ICU settings where the patient neurological emergence neuro ICU patients are there. They want to know whether ICP is raised or not. It has been very less done in non-traumatic settings and in emergency departments, where it is actually very needed. Where patients come to emergency department and we want to know whether the patient is having a raised intracranial pressure or not. So this study which I have done is in the emergency department. A short title of the study is ocular ultrasound to detect raised intracranial pressure in non-traumatic emergencies in the emergency department, such as spontaneous IC bleed or midline shift secondary to edema due to stroke, or other causes like acute fulminant liver failure or congestive cardiac failure or decay. There are many reasons of non-traumatic emergencies which are causing raised ICP. So the aim of my study was to measure the accuracy of optic nerve sheath diameter measurement by ultrasound as a non-invasive method for early detection of raised ICP in patients with non-traumatic emergencies who come to emergency department, and compare these values with the findings of CT and MRI brain scans, whether it correlates or not. And the objective of the study was to find the efficacy of the ultrasound-guided ONSD measurement in detection of raised ICP, how efficacious it is by comparing it to the CT and MRI brain scan findings. We kept CT MRI as a baseline because in emergency department, we can't go for invasive ICP monitoring, such as putting a ventricular drain in each and every patient. So the sample size of the study was 100 patients. And we included all patients who in whom we suspected raised ICP with a non-traumatic history. And it included patients more than 18 years and less than 80 years. Patient who came with altered mental status, patient in whom we suspected meningitis or encephalitis, patient who were persistently vomiting, having non-resolving headaches, having blurring of visions, patients who showed signs of meningism on a neurological examination, patients with some new onset neurodeficit like unresponsiveness, unilateral weakness, other issues, and also patients in whom the cerebral edema has been shown to be a complication, like diabetic ketoacidosis, ischemic infarct, hypertensive encephalopathy, acute liver failure, cerebral sinus venous thrombosis, etc. So these patients were included. Who were excluded? Patients less than 18 years and more than 80 years. Second, patients with obvious head injuries and polytraumas, patient who had orbital traumas or ocular traumas, patient who had neoplasm in the optic nerve, which would have changed the anatomy of the area, patients who had lens opacities, and patients who had a lot of cerebral atrophy, because cerebral atrophy gives a lot of space for, so the edema does not develop. Even if there is an edema, the symptoms does not come. So we ruled those patients, we excluded those patients. And all patients who underwent any kind of neurosurgical procedures like decompressive cranectomy, etc., they were not included in my study. How we did the study? We use the B mode of ultrasound, that is also called brightness mode or 2D mode. We use the linear probe of 7.5 megahertz, as you can see in the picture. And while resting on the closed eyelid with minimal pressure, so that it does not increase the optic nerve sheath because of the pressure, we measured the optic nerve sheath behind the optic disc, with the optic disc being in the cross section around 3 mm behind the optic disc, and we measured the optic nerve sheath from end to end. This is how we measured it. What were the MRI and CT findings that were used to compare whether the patient, like we did an optic nerve sheath diameter assessment, and then we send the patient for an MRI or a CT depending on the condition of the patient, and what things we saw in the MRI or the CT scans to say that this patient had raised intracranial pressure as a reference point. like a patient having effacement of ventricle. If one side the patient has a bleed and that is effacing the lateral ventricle, that was one of the criteria. Then effacement of basal cistern around the midbrain, around the brainstem. Then tortuosity in the optic nerve. The optic nerves are usually in a straight line, but if it becomes tortuous, it means there is a raised ICP that is causing tortuosity. Of course, it is present very rarely in some normal patients also without a raised ICP. Flattening of the optic disc flattens when there is a raised ICP. Also, brain herniations like transtentorial herniations, loss of gray-white differentiation, and empty sella. And if all the ventricles are dilated, it was suggestive of hydrocephalus. These are the findings that we saw in the MRI scan. What we saw in the CT, loss of sulci gyri in the area of the bleed, midline shift of more than 5 mm we considered as raised ICP, compression of the third ventricle, effacement of the basal cisterns, and signs of brain herniation, which was also visible in the MRI findings. Also, in patients with normal pressure hydrocephalus, there is something called Evans index, where we measure the dilatation of frontal horns as compared to biparietal diameter. If it is more than 0.3, it means the patient is having raised ICP. So these were the findings that we saw in the imaging to say, okay, the patient has raised ICP. So when we compared these findings with our ONSD values, which we saw, so we divided the patients into two groups. Group number one is patients who had CT MRI findings of raised ICP. We'll say that group number one henceforth. And group number two who had no CT or MRI brain scan findings of raised ICP. So patients in group number one, when their ONSD values were checked, the mean came around 6.8. That was very high. For the study, we took as 6.3 as the cutoff. Means we took if the patient had a ONSD value less than 6.3, we considered it normal. And patients who had ONSD value more than 6.3, we considered abnormal. This was based on Pablo et al. Study and Gupta et al. Study that was done in the past in the same topic. So patients in group 1 has a mean ONSD of around 6.8, which was well above the 6.3 cutoff. And patient in group B had a mean value of around 5.7 when it was compared with the CT MRI findings. This is the table of comparison. You can see there's a wide gap between the two mean ONSD values of group 1 and group 2. Also, patients who had patient who did not, this is another way of presenting it. Patients who have had CT MRI brain scan findings of raised, everybody on the left hand side, everybody had ONSD cutoff of were above the ONSD cutoff of 6.3. Means if the CT MRI findings were there, patients had ONSD value more than 6.3. Whereas in group 2, patient who did not have CT MRI findings of raised ICP, 89% the ONSD value came below 6.3, and only 10% patients had raised ONSD value, but there were no CT MRI brain scan findings of raised ICP. So this is the association between two. So based on that, an ROC curve was plotted. The area under the curve was 9.95 and with a cutoff of 6.3, which showed 100% sensitivity and 89% specificity. Further on, the negative predictive value was 100% and positive predictive value of the study was 83%. We compared other aspects as well in the study, like comparison of these two groups with the GCS score with which the patient came. Patient of group 1, that is presence of CT MRI finding of raised ICP, they had an average GCS, a mean GCS of around 10.72, while the patient of group 2 had a mean GCS of 12.5. So there was a statistically significant difference between the two groups. Means GCS was comparable with CT MRI brain scan findings. This is the tabular representation of mean, median, and range of the GCS values. Another thing that we compared was presence or absence of seizures, like patients in whom we suspected raised ICP, how many patients came with history of seizures to the emergency department. So there was no significant difference between the two. Patients who had group 1, they had almost the same number of patients in presence or absence, having or not having seizure as compared to group 2. So there was no statistical difference found. This is the tabular representation of that. The third thing that we checked was headache. How many patients who presented with headache had raised ICP and how many did not. So there was a statistical difference. Out of group 1, 54% patient had history of headache, while 45% did not. And out of group 2, only 15% had headache, and 84% of patients who did not show any CT MRI plain scan findings did not have headache. This is a tabular representation of that. And the last thing that we checked was whether the patient had history of nausea, vomiting. So there was no statistical difference between the two. Patients of both group A and group B, group 1 and group 2 had similar incidences of nausea and vomiting. So what was the recommendation based on the study? The first thing is the important why it is a very good tool, that it is simple. It is rapid. You don't have to wait for a long time. It is non-invasive. Patient is not harmed. Very cost effective, unlike CT scan, MRI, fairly accurate, and it is repeatable. If you're not sure, you can repeat it again. And readily available method to detect raised ICP in medical emergency with suspicion of raised ICP. Second thing is bedside. What is the recommendation? This bedside ultrasound ONSD measurement should be done for all cases in whom we are suspecting raised ICP, not just trauma. If the patient is having altered mental status, we should get a raised ONSD done. Increased ONSD is a reliable indicator of raised ICP, as we have seen in the study and past studies also. If we have increased ICP, increased ONSD value, we should suspect raised ICP because it is a very reliable indicator. And emergency physician should be trained in ultrasonographic ONSD measurement for early detection of raised ICP and to reduce inter-observer variability. And fifth, and the most important, it was only a 100-patient study. A larger studies are needed to be carried out to further strengthen this evidence. What are the limitations of this study? Sample size is very small, only 100 patients. Second, CT MRI is not a direct measure of raised ICP. It is a pragmatic measure. It is a very practical measure. The gold standard is always invasive ICP monitoring by putting a ventricular drain, but we can't put in every patient of raised ICP. So we need to settle for a practical indicator, that is a CT MRI scan. It fairly gives an idea which patient has a raised ICP, which does not. And we use that because in ED, we can't go for ventricular drain in every patient we suspect a raised ICP. So that is one of the limitations. Study is prone to bias as it was a convenient sample. We took whatever patient come to the emergency department and not randomized it. Only one recruiting resident was there for the study, and hence inter-observer reliability was not recorded. And patients who underwent neurosurgical procedures, when they came to emergency, we could not include them in the study, and we don't know, we don't have an idea how to check raised ICP in those patients as of now, as per my study. And fifth and important is the relationship between comorbidities and neurological examination was not compared in the study, as it would have made the study very vast. The conclusion of this study is, the study shows that bedside ONSD measurement seems to be a useful and fairly reliable technique for the detection of raised ICP without compromising patient's emergency care. You don't have to move a very sick and very unstable patient to the CT scan or MRI department. That is very good point. It allows a suitable and harmless screening of patients with non-traumatic emergencies with raised ICP. You don't have to put an EVD. You don't have to subject the patient to more harm. Third, we use B mode of ultrasound called brightness mode or a 2D mode, which does not produce harmful temperature rise. It is very safe for the patient. It does not harm. That's why non-invasive. And bedside ultrasonographic measurement has a potential to be used as a clinical research test for raised ICP. The technique can be validated in larger trials. We need larger trials to validate this result, so that it can be put in normal practice. Like a patient who comes with this suspected raised ICP, we got a high ONSD and it is validated in larger trial, we can go ahead with anti-edema measures without waiting for an MRI or CT scan to confirm our findings. Thank you very much.
Well, Dr. Qamar, that's a very good study with the quality data collection. Hope we continue the study and overcome all the limitations of the study. So let us quickly proceed to the question and answer session. Coming to the first question, how do we measure optic nerve sheath diameter using bedside ultrasonography? I think the question is about the procedure to how to measure the optic nerve sheath diameter. Dr. Fani, can you answer this?
Yes, actually the linear probe of the ultrasound is used to measure the optic nerve sheath diameter, and the patient is lied supine. with a 20 to 30 degrees head tilt up, and the measurement is done by placing the linear probe over the um, over both the eyes, and then it is taken as a 3 mm distance behind posterior to the globe, and then it is measured. Why this 3 mm distance has been taken is because the contrast of the ultrasound is highest at this point, and also the results are more reproducible. So that is why this distance of 3 mm has been taken as the cutoff point, and then it is measured. Yeah.
Yes. The next question is, what is Pico model? PICO, Pico model. I'll take this question. Basically, the Pico model, it is regarding the research question. It helps us to state what our research question is. As I have already discussed, formulating the research question and finding what is the topic of interest of our research is very important thing. Here, the Pico model, it states our research question in the form of the P standing for the population that we are interested to conduct a study, whether it is the patients or whether it is the population. I stands for the indicator or the interventions that we are planning to do. C stands for the comparator or the control group with which we are comparing this study group. And O stands for the outcome. So this gives a fair good idea about the research question. The next question is, what is the cutoff value of ONSD to say that the ICP is raised? Dr. Fanny, can you continue the answer?
Yes, the cutoff value for ONSD means is taken as 5.7 to 6 mm in adults. So anything above this, we can term it as that the patient might have a raised ICP. And in pediatrics and infants, the cutoff value are a bit on the lower side.
Okay. Coming to the next question, optic nerve sheath diameter is measured with in which mode of ultrasonography? Dr. Qamar, can you tell us this?
As I mentioned in this presentation, it is used in the B mode of ultrasound is used. There are 3 modes basically in ultrasound: A mode, B mode, and M mode. A is the amplitude mode, B is commonly called brightness mode, and M is the motion mode. B mode, it's actually brightness mode, or some people call it 2-dimensional mode. It gives a 2-dimensional picture of the body wherever you are scanning. So you can tell the distance from point A to point B, and also the depth also you can tell. So you can actually measure what you want to measure in the B mode. So this optic nerve sheath diameter assessment, we need the optic nerve sheath diameter. So we use the B mode of the ultrasound to measure the diameter of the, as it is a 2-dimensional image. In a 2-dimensional image, there is an x-axis and a y-axis. So it gets easy to measure any structure that is visible. So, and also brightness mode, the reason why it is called is because echogenic things are brighter and echogenic things are darker. That's the reason. And that's why we use the B mode of the ultrasound.
Okay. The next question is regarding research team. Who comprise a research team? I'll take this question. Basically, the research work is also a very good teamwork, just like we work in our emergency rooms. And the research team consists of a clinical epidemiologist who guides us regarding the plan of a study, how we should go forward regarding our study. A biostatistician, we take help of a biostatistician who determines the size of the sample and the statistics that are required for the study, how we collect the data, how we analyze them. And it consists of the senior investigator and aspiring or a co-investigator who help in writing the results of the study and taking it forward. The team also consists of a project manager who manages the budget and fixes the timelines and records that are to be submitted to the funding agencies. This is the part of the research team. And the next question is about what are the cautions that we have to take while assessing the ONSD. Dr. Fanny, can you tell us about this?
Yes, sir. Any procedure we have to be a bit cautious because there are some complications and consequences. and also underlying causes might be there. So nothing different in this also, because we are doing it and it is a non-invasive thing. We'll be putting, as we have mentioned in the presentation and also in the Q&A session, that we'll be placing the linear probe on the eyelids and all. So whenever a traumatic patient comes in and if you are suspecting a globe rupture, any manipulation or pressure on the globe of the eyelid should be avoided, because this manipulation can hurt the patient, and we can and the results of our study, means like the procedure, might not be as accurate as possible. And the other thing is orbital emphysema, where it makes very difficult to visualize the contents of the orbit. So we have to see whether there is an orbital emphysema or not before doing the ONSD. And the other thing is regarding to the trauma itself again, because any trauma to the globe, what happens is there, while you are visualizing, the vitreous might have some air bubbles, and these air bubbles might resemble as an intraocular foreign body. So if at all these things are there, you have to be very cautious while doing the procedure and while measuring the ONSD, because it can alter your values and your readings and all.
Yes, we have to take precautions so that our own interventions don't raise the intraocular pressure further. Okay. Coming to the next question. If the bedside ultrasound shows raised ONSD, but the imaging is normal, what would the approach be towards the patient? Okay. Dr. Qamar, can you tell us about this?
Normal imaging. It's a very good question. It's a very clinical question. If suppose we got an MRI or a CT, we found raised ICP features, we'll give anti-edema measures, fine. But if we got a raised ONSD value and if the MRI is normal, if the CT is normal, what to do next? Very clinical. We should suspect a raised ICP in such patient, because 10% of the patients whom raised ONSD value were there, the CT MRI brain scan findings were normal. So how to approach? The patient may have a raised ICP, may not have raised ICP, because MRI or CT is also an indirect measure. They can't pinpoint that this patient has. The only gold standard thing is ventricular drain that can accurately tell whether the patient has raised ICP or not. MRI and CT is also indicates. So in such patient, we should take precautions so that ICP does not rise further. That we usually take in trauma patients and non-trauma patients also, like head end elevation 30 degrees in an unresponsive patient. That drastically reduces the ICP that is raising when the patient is kept flat. So head end elevation is a good option. Second, we can loosen the ET tube tie. ET tube is tied around the neck. So if it causes the jugular vein drainage decreases because of that. So that causes raised ICP. Such patient in which we are suspecting raised ICP, we can loosen the tie of the ET tube, so that that also contributes a bit. Third, we can consider sedation in very agitated patients. Agitation again increases the ICP. So we can consider sedation. Fourth, we can consider avoiding drugs that causes ICP increase, like ketamine, like succinylcholine, other drugs. Fifth, if we clinically suspect that this patient has raised ICP despite MRI findings, we can take anti-edema measures like mannitol and 3% NS, and we can go ahead with a neurosurgery opinion for that. So these are the things that can be done in such patients. Hope I answered the questions.
Yeah. Okay. So this ends the question answer session too. Thank you, Dr. Fani and Dr. Qamar, for your wonderful presentations. I thank each and everyone for your valuable time. Thank you.